Coming up, I've experienced this quite a lot working at various sites in the last few years. So, I've worked at some comprehensive stroke centres where we have a very large catchment area geographically of a radius of hundreds and hundreds of kilometres. And so, we get the call about someone who is a thrombectomy candidate, but they're 4 hours away, 6 hours away. We say yes. And then we wait for them to arrive, and then they arrive, and then there's been a clinical deterioration. So then the interventionalist then asks for repeat imaging, and we repeat the angiogram plus or minus a repeat perfusion, and then based on the clinical and radiologic characteristics, the patient then isn't a thrombectomy candidate anymore. So they were when we got the phone call, but then they weren't by the time we got here. Hello, and welcome to the next installment of Risfeld Neurology Education, a not-for-profit, free open access project with a philosophical touch, exploring all areas of clinical neurology, meant for medical students through to neurologists and any health professional caring for patients with neurological conditions. I'm your host, Tom Risfeld, a neurologist, epileptologist, and neurophysiologist and neuromuscular specialist, and also a physician, philosopher, and bioethicist. I'm really excited to pronounce that this will be the first Journal Club episode, and it also falls within the Stroke and Cerebrovascular Diseases series, and it's titled Tenecteplase for Stroke to 24 Hours, Trace 3 Study Journal Club. Before we begin, a legal disclaimer: the content of this episode is for educational purposes only. Also, any post-publication corrections which I come across will be included in the video and audio podcast descriptions as always. So, why am I doing some Journal Club episodes? Well, the episodes that we've done so far, the previous 18 episodes in Risfeld Neurology Education, have been more foundational and clinically focused overview episodes. But I thought that it would be good to produce some content which is perhaps a deeper dive for some of the more senior audience members, so neurologists and neurology advanced trainees. Although I do think that it will be quite useful and interesting for some of the more junior audience members as well. And it also develops skills in terms of how to understand research articles and how to critically appraise research articles so that you can critically evaluate and derive conclusions from the literature as you should, rather than just trusting things and taking it for granted without really looking into the devil in the detail. And also, I've done a few Journal Club presentations for work recently, and we're coming to the end of 2025 now, and I thought that I should try and release the content before it becomes outdated. So here we are. And the first presentation I've chosen to do is following on the stroke episodes that we've released recently. And it's a paper that was published in NEJM last year in 2024. And it's titled Tenecteplase for Ischemic Stroke at 4.5 to 24 hours without thrombectomy. So this is the abstract here that I've included for those watching on video. So if you want to read it, you can have a pause and have a read. But I'm going to skip through it because we're going to go through the whole paper now. So let's dive into it. So this is setting the scene. Why is it important to evaluate tenecteplase? Well, what do we do at the moment? So we know that alteplase is approved for thrombolysis for acute ischemic stroke up to the 9-hour mark from the time of last seen well, or from the midpoint of sleep, as we discussed in the previous episode that I released. We also know that studies have demonstrated that tenecteplase is non-inferior to alteplase, and it is approved for up to use to 4.5 hours. In all of the hospitals in Australia that I've worked in, they have tenecteplase for acute coronary syndromes, but it's not on the formulary for acute ischemic stroke currently at the time of writing in November, December 2025. However, it is coming very shortly. And everyone's looking forward to that because, of course, alteplase is difficult to draw up and administer because you have to get the powder, mix it with the solution, draw it up into a big syringe, give the first 10% as a bolus over a minute, and then the remaining 90% over an hour. So it has to be put in either a syringe driver or in a burette and a bag and run through. And all of that fiddling and finicky drawing up is actually tricky, and it can contribute, I think, at least anecdotally, to door to needle times. And if you don't have an experienced nurse who knows how to do it, and if you, as the doctor, as the neurologist, or as the basic physician trainee, are not someone that works in ICU and ED environments all the time, and you're not that used to drawing up solutions and mixing solutions and setting up urettes and syringe drivers and things like this, it might put you out of your comfort zone as well. Whereas Tenecteplase has the major advantage that it's just given as a push and it's not finicky in this way. Also, even though it's been demonstrated to be non-inferior to alteplase in these studies, there has actually been some meta-analyses of the randomized controlled trials which have demonstrated that it's not just non-inferior to alteplase, it's actually superior to alteplase in patients with LVOs presenting in less than 4.5 hours. So we know that in Australia, at least, we use alteplase predominantly for acute ischemic stroke, but tenecteplase is on the cards as well. And we can use alteplase up to 9 hours, but we can't thrombolyze beyond 9 hours with the current body of literature. And then this trial comes along to say, well, can we push it further? Can we push it out from 9 hours to 24 hours? And why is that important? Well, about 2/3 of patients, or up to 3/4 really, so 67 to 75% of patients with acute ischemic stroke present at beyond the 4.5 hour mark. So the population of patients who would potentially be a candidate for thrombolysis would increase dramatically if we could push it out from, say, 4.5 hours for tenecteplase or 9 hours for alteplase up to 24 hours with tenecteplase. Now, is this the first study that's looked at this? No, there's been one other major study, for instance, called the Timeless study, and that was also published in NEJM also in 2024. And that reviewed tenecteplase up to 24 hours for patients with a large vessel occlusion, an LVO, with evidence of salvageable penumbra on perfusion imaging, and it was a negative study. However, the majority of patients underwent immediate mechanical thrombectomy. And that's hypothesized to have at least partly, if not wholly, explained the negative result of the study. So, what the authors of this article wanted to do was to look specifically at the population of patients who did not have mechanical thrombectomy available to them as an option because it just wasn't practically available. So, worldwide, many patients do not have geographical access to mechanical thrombectomy, especially in low and middle income countries. And even in high-income countries that are geographically large, there may be pragmatic geographical reasons why access to thrombectomy may be limited. So, for instance, Australia is a very large country geographically, and even though the majority of the population lives in major urban centres, it's very relevant in regional, remote, and rural medicine where patients do not live in areas which are thrombectomy capable. And so we have to organize transfers either by road or by helicopter or by plane. And even then, if you're right in the middle of the country, even a helicopter or a plane transfer can be very slow, or there may be competing medical retrievals that the air ambulance service needs to perform. So, sorry, not the air ambulance service, the retrieval medicine service needs to perform. So there may be times when a patient in a high income country such as Australia still is not able to have access to a thrombectomy centre. So that's a really important point to note. It would be very meaningful on a global scale if the time window for thrombolysis could be brought out for 24 hours. We know that tenecteplase isn't cheap either, however, but bearing that in mind, it would still dramatically increase treatment options for stroke patients. So, the study that we're looking at, the TRACE-3 study, TRACE-3 study, aims to explore whether tenecteplase in the 4.5 to 24-hour window in patients with an LVO and with salvageable tissue on perfusion imaging, when there is not access to mechanical thrombectomy, benefit. And that's the distinguishing point from the Timeless study. So, how was the study performed? In regards to the trial design and oversight, it was a phase 3 multi-center study across 58 centers, although they were all in China. And that's potentially relevant because this is an Eastern population as opposed to a Western population. And we know that the mechanism of ischemic stroke does differ epidemiologically between Eastern and Western populations. So Asian populations have a relatively higher percentage of strokes which are caused by ICAD, intracranial atherosclerotic disease, compared with the proportion that's seen in Western populations. And conversely, Asian patients have a lower percentage of atrial fibrillation AF-related ischemic strokes relative to the percentage which is seen in Western populations. It was a prospective randomized trial, and it was blinded partially. So it was blinded in terms of the outcome assessment and the statistical analysis, but it wasn't blinded at the time of administration of the medication. So it wasn't triple blinded, it was double blinded technically, but the two blinding points were at outcome assessment 3 months down the track and at the time of statistical analysis. But at the time of administration, right at the get-go, that was not blinded. That component was open label. And that was for pragmatic reasons, I would presume, and safety and ethical board reasons, I would presume. The trial protocol was prospectively approved at each site, of course, and the Tenecteplase and the infrastructure for the trial was supported by an unrestricted grant from the pharmaceutical company providing the medication, which was a Chinese pharmaceutical company. However, the company did not participate in the trial design, the trial conduct, the manuscript drafting, or the publication process. And in terms of the other potential financial competing interests or the other ways in which the study was financed, research versions of an software under the proprietary name iStroke was provided for free to the trial centres by two other companies. Which patients were included? So firstly, it was in adults, so 18 years old and over. Of course, they had to have stroke, and that included stroke with known onset time, but also wake-up strokes and also unwitnessed time of onset strokes. It had to be within 4.5 hours and 24 hours from the time last known to be well. And it didn't comment on the manuscript as to whether they used the midpoint of sleep or not for wake-up stroke. So I'm actually not sure whether they used that midpoint of sleep method that we talked about in the last episode on this channel or not. This is important. So the patients all had a baseline modified Rankin score of 0 to 1. So you'll remember if you listened to or watched our last episode that when I think about hyperacute stroke medicine, I typically draw a firm line in the sand between an MRS of 3 and 4. And generally speaking, I think if someone's got an MRS of 3 or below, then you get the green light and you're a potential candidate for hyperacute evaluation. Whereas if you're a 4 and above, then that's a red light and you're not a candidate for hyperacute stroke evaluation if you're going by the books. But this study only enrolled patients with an MRS of 0 to 1. So these are very, very, very healthy patients from a functional perspective at baseline. So they have either no symptoms at all, MRS 0, or they have symptoms but absolutely no functional impairment whatsoever. So that's an MRS of 1. So they can still play golf, do all their hobbies. They're not restricted in any way whatsoever. In terms of the clinical severity of the strokes, they had a NEIS of 6 to 25. So that's relevant. So there have been some recent studies looking at minor non-disabling strokes with NEISs of 0 through 5. So patients with a NEIS of 5 or lower were not included in this study. And we talked in the last episode that although historically patients with a very high NEIS in the high 20s and into the 30s were excluded from thrombolysis and clot retrieval, that's not usually considered to be an absolute contraindication these days. Although in this study, it was only patients up to a NEIS of 25. So that's still a very high NEIS, but you weren't getting patients with NEISs of 28, 32, 35 in this study. Now, how did they define LVO? So it had to be an intracranial internal carotid artery, an ICA, or an M1 or an M2. They didn't make any distinction between proximal and distal M2 or dominant and non-dominant M2 in terms of their definition of whether it's an LVO or a MEVO, a medium vessel occlusion. And I did say in the last episode that a non-dominant M2 or a distal M2 by some would be considered as a MEVO, although others would still consider NEM2 an LVO, so that's a bit of a grey area. For practical purposes in clinical practice, usually an M2 is still considered fair game and an LVO in terms of possibility of mechanical thrombectomy. So how did they define salvageable tissue? Well, this is done on CT perfusion or MR perfusion. So how did they define salvageable tissue? Well, of course, that's done on perfusion imaging. So that's on a CT perfusion or sometimes on an MR perfusion. Using CT, they define core as is normally done with a CBF, a cerebral blood flow of less than 30% relative to the surrounding normal brain tissue. Or using MR perfusion, it was defined as an ADC value of less than 620 times 10 to the minus 6 millimeters squared per second. Then how did they define penumbra? So that was defined as a T max of greater than 6 seconds. And of course, the T max also includes the core as well. So really it's the core plus penumbra is a T max of greater than 6 seconds. And the requirements for inclusion as meeting the criterion for salvageable tissue is basically that you had to have a core that wasn't huge and you had to have enough penumbra to make it worthwhile. So that means that you needed to have a core that was less than 70 millimeters. And then comparing the amount of core with the amount of penumbra, you had to have a mismatch ratio of greater than or equal to 1.8 and also a difference in volume of at least 15 milliliters. So I hope that makes sense. I'll say that again. So the core had to be less than 70, the mismatch ratio had to be greater than 1.8, and the difference in volume had to be greater than or equal to 15 milliliters. And then this is the important point, as mentioned earlier, the patients were excluded if mechanical thrombectomy was planned at the time of randomization, or of course, if there were any contraindications to thrombolysis. So the patients were randomly assigned in a 1-to-1 ratio, and randomization was performed through a centralized permuted block method. The randomization was stratified according to the vessel occluded, so either intracranial ICA versus M1 versus M2, and that was so that they didn't by chance randomize a huge bunch of patients in one study arm to, say, an intracranial ICA, and then they didn't by chance randomize a whole bunch of patients into the other study arm with M2s, for example, so that they're at least balanced. The clinical outcomes were performed by qualified physicians, and outcome events were adjudicated by a blinded committee. So how is the intervention actually administered? So the Tenecteplase was a single bolus over 5 to 10 seconds. So you can see how much easier that is than Alteplase, which you run the first 10% over a minute and then the remainder 90% over the next hour, as I mentioned earlier. So it's just one push over 5 to 10 seconds. And the dose is 0.25 milligrams per kilogram up to a maximum of 25 milligrams. So that's different to Alteplase, of course, although the idea in terms of the maximum is still the same. So Alteplase is 0.9 milligrams per kilogram up to a maximum of 90 milligrams. So basically, if you're 100 kilograms, you then max out the dose. And that's the same in terms of maxing out the dose here. So if you're 100 kilograms for Tenecteplase, that's when you're maxing out the dose. So if you just remember 0.25 milligrams per kilogram, and then maxing out the dose at 100 kilograms, which is then 25 milligrams. The control just received standard medical treatment, and that usually consisted of antiplatelets at the discretion of the treating physicians. And rescue mechanical thrombectomy was permitted if there was a subsequent clinical deterioration and mechanical thrombectomy was subsequently considered to become accessible. It was stated in the supplementary material that patients who had an initial stroke after hours in a mechanical thrombectomy center with less than 24/7 availability and then had a subsequent deterioration in hours when mechanical thrombectomy became available accounted for most of these patients. So that makes sense. If you've got a center that offers thrombectomy between 8 a.m. and 5 p.m. Monday to Friday, and someone comes in with an acute ischemic stroke at 4 a.m. on Monday morning, there's no mechanical thrombectomy available, so they couldn't have thrombectomy. They were randomized into the study, and then 6 hours later, they had a further deterioration, and so a repeat stroke call was made, and then they do still have an LVO, and then it's after 8 a.m., so they're already in a thrombectomy center, and now they're in ours, so they can have thrombectomy. And importantly, these patients were included in the intention to treat analysis, which was what was used in the primary analysis, but they were excluded from the per protocol analysis, which was then included in secondary outcome measures. And only a small number of patients in both the treatment group and in the control group applied to this concern. Outcomes. I've already hinted at these. So the primary outcome was absence of disability, so defined as an MRS of 0 or 1 at 90 days. Secondary outcomes, as usual in stroke medicine, included ordinal distribution analysis of the modified Rankin at 90 days. So that's when you see those bar graphs, and I'll show them later, so I won't talk about that now. Then functional independence, which was defined as an MRS of 0 to 2 at 90 days. So you'll remember an MRS of 2 is you can't play golf as well as you used to be able to, but you're still completely functionally independent when it comes to your instrumental and also personal activities of daily living. Then they also looked at major neurologic improvement at the 72-hour mark after treatment, and that was defined as a reduction from baseline of 8 or more points in the NIHSS, or having an NIHSS score of 1 or less. They also looked at reperfusion at 24 hours after treatment, and that was defined as a greater than 90% reduction in the volume of the Tmax lesion if repeat perfusion imaging was performed. And they also looked at change in baseline NEIS at the 7-day mark. So they were all the secondary outcomes that they looked at. They also did an exploratory secondary outcome assessment, which was recanalization at 24 hours following treatment if the patient had repeat angiographic imaging to assess for recanalization at the 24-hour mark. Safety outcomes. Well, obviously they were interested at looking at symptomatic intracranial hemorrhage, and that was defined as any intracranial hemorrhage resulting in death or resulting in an increase in the NEIS of greater than or equal to 4 points within 36 hours. And they also looked at death from any cause and moderate to severe systemic bleeding within 90 days. And then they also looked at adverse events, including serious adverse events, other than the ones I've already mentioned, within 90 days. So in order to assess some of these secondary outcomes, patients had a repeat CT perfusion or MR perfusion at 24 hours to assess these, and a repeat non-con CT or MRI at 24 to 36 hours to assess these safety outcomes. Outcome assessment was performed by clinicians who were blinded, and the other data that was obtained, of course, was demographic information, the patient's medical history, medications, and select laboratory test results. So, how is the statistical analysis performed? As I mentioned earlier, the main analysis was performed on an intention to treat basis. So that means that patients were randomized into either the treatment group or the control group, and then if there were any protocol violations and patients skipped between one group to the other or dropped out, those patients were still included in the analysis in the group that they were initially randomized to. However, per protocol analysis was also performed, as I mentioned, as one of the secondary analyses, and that was patients who had had major violations in the trial protocol. And in particular, that was patients who then received rescue thrombectomy when thrombectomy became available following a clinical deterioration in hours as opposed to out of hours, as I just talked about. The results were reported as unadjusted rates and 95% confidence intervals, and the distribution of MRS was analyzed according to ordinal logistic regression and reported as odds ratios. And then some of the other outcomes used different methods. So improvement at NEIS at 7 days used generalized linear mixed modeling. They also did do some secondary outcome analyses by imputing or extrapolating data when some data points were missing. The way that they actually wrote this in the paper, I'll quote, was a multiple imputation method that was used on a fully conditional specification method was used to impute missing data for the secondary outcomes for which data were missing. This seems a bit sneaky to me, I must say. I'm not a statistician, I'm not a mathematician. It did just seem a little bit sneaky, but I'll let you come up to your own mind there. But importantly, this was just for the secondary outcomes. It wasn't for the primary outcome analysis. Then they did pre-specified subgroup analysis. And of course, it's important that it was pre-specified to avoid any ad hoc p-hacking after the fact. So pre-specified subgroups, and they were defined according to some demographic factors. So age, less than or greater than 80 years, sex, baseline severity of stroke, so it needs of less than 10 or greater than or equal to 10. The interval between the time that the patient was last known to be well and the treatment, so between 4.5 and 9 hours compared with 9 to 24 hours compared with stroke on awakening, and then large vessel occlusion strike, as I mentioned earlier. They did also do post hoc analyses of functional outcomes using logistic regression with adjustments for age, sex, baseline NEIS, the interval between the time last known to be well and randomisation, and the occlusion site. And some of the other subgroups that they then defined in this way were age of less than 65 to greater than 65 years, whether the patient had endovascular thrombectomy as a protocol violation or not, and also the volume of the ischemic core at baseline, so less than 20 mils versus 20 to 50 mils or greater than 50 mils. And they used the SAS software for their statistical analysis. So the results, this is what you've all been waiting for. So firstly, the demographic components. The patient characteristics, they were enrolled between 2022 and 2023. There were 1,500 patients screened, and about a third of these, so 516, were selected. And then about half of these were randomized to Tenecteplase, and about the other half were randomized to placebo. There were these protocol violations in 28 patients, so about 5% of the patients, and of them, 9 patients had an unrecognized infarction affecting greater than 1/3 of the MCA territory on the non-contrast CT. And this was actually meant to be an exclusion criterion to enrollment, but it was missed. So those patients were accidentally enrolled because the infarction of greater than a third of the MCA territory of the non-con CT was missed at the time of enrollment. And that's important because that's actually a really important contraindication to thrombolysis because it's a massive risk factor for hemorrhage. And of the 9 patients that were accidentally enrolled, 5 of those 9 patients had a symptomatic intracerebral hemorrhage, although it wasn't actually stated at the time whether they were in the thrombolysis or the placebo groups, but it is stated later. And then 9 patients had rescue mechanical thrombectomy, 4 of whom were in the Tenecteplase group and 5 of whom were in the placebo group. This is quite important. The median time from last seen well was 12.3 hours. So most of the patients were not in the 4.5 to 9 hours. Most of the patients were in the very extended time window, so more than 9 hours, so beyond what we would even do Alteplase for. And the interquartile range here was 8.5 through to 16.4 hours. The imaging modality used was CT perfusion in 87% of the patients and MR perfusion in the remaining patients. And that's consistent with my experience in Australia as well, which is that the vast majority of patients have a CT perfusion, and usually MR perfusion is reserved for patients who are, say, getting a hyperacute MR because they're at truly unknown time of onset as opposed to a wake-up. This slide here, for those watching online on the video format, is the initial flowchart, although that just demonstrates everything that I've just spoken to already, so I'll skip over that. Now, this is table 1, which is the baseline characteristics, and in almost all clinical studies, so randomized controlled studies and other studies, this is usually going to be your first table. So this is showing were the clinical characteristics between the two groups relatively even, or were there any major differences between the group which may have skewed the outcomes? Now, they're all pretty similar. I've just highlighted a few things which are relevant. So firstly, the median volume of perfusion lesion at initial imaging was really similar between the two groups. So in the Tenecteplase group, it was 119 mils, and in the control group, it was 123 mL, so extremely similar. So they did well there. And most of the other parameters were very similar as well. The two that were a bit different were the timing of the onset from the stroke. So unwitnessed onset was very similar between the two groups, but in the Tenecteplase group, there were more wake-up strokes and fewer known onset time. And in the standard medical treatment group, so the control group, there were fewer wake-up strokes and more known onset times. The difference wasn't huge, so in regards to the wake-up strokes, it was 38% in the Tenecteplase group and 33% in the control group. And conversely, the known onset time was 54% in the Tenecteplase group and 59% in the control group. So that's just something to be mindful of. Although I don't think it should really affect our take-home messages from this study. Now, this table here looks at some of the additional characteristics that were looked at, such as whether the patients were on antiplatelets, whether they were on anti-cholesterol therapies, hypoglycemic drugs, etc., 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 etc. I'm not going to go through this in the interest of time, but I will say that they were very similar between the two groups, which is good. That's what you want. But the one thing I will point out here is that the door to needle time, of course, there's no door to needle time in the control group because there's no needle because they're not being thrombolized. But the door to needle time in the Tenecteplase group was, wait for it, 139 minutes. I'll say that again, 139 minutes. That is mind-boggling to me. 139 minutes. We aim for less than 30 minutes. Less than 30 minutes is you get to pat yourself on the back and smile and look happy when you get home that day, and you can tell your family about this great door to needle time you got of less than 30 minutes. That's when you get to celebrate as the doctor involved in the stroke call, or as the nurse or any other health professional involved in the stroke call. That's the aim, 30 minutes. Realistically, you don't get 30 minutes that often. All the ducks have to align. All the stars have to be perfectly aligned to get a sub 30 minutes. You need to have pre-notification. You need to be there waiting. The patient needs to have a cannula. It needs to be an obvious stroke syndrome. All the imaging has to go really well. You have to draw it up quickly, get it in. There needs to be no contraindications or issues with consent. So it's hard to get a sub 30, but that's the aim. Realistically, it's probably more likely that you're getting between, say, 30 and 40, 45. But 139 is just bonkers, I think. And I then spoke with some colleagues about this and read the rest of the paper, and they do discuss that 139 minutes is actually not so unusual for a clinical trial environment, because the clinical trial environment slows everything down enormously. And I'll talk to that a little bit later on. Now, the primary outcomes and the secondary outcomes. So the primary outcome, which group did better? Which group at 90 days had an MRS of 0 or 1? Well, in the Tenecteplase group, 33% of patients did, and that's despite having that really long door to needle time, as I just harped on about. Whereas in the placebo group, 24%. So 33% compared with 24%. And the effect size there was 1.37, and the 95% confidence interval was 1.04 to 1.81. Now, they didn't actually publish p-values, but you don't really need them, because the definition of a p-value being less than 0.05 is if the 95% confidence interval does not cross 1, and the confidence interval did not cross 1, so we know that that meets the threshold of statistical significance. And of course, p-values have been somewhat criticized recently because the whole 95% or the 0.05 is a completely arbitrary number to draw. It's a completely arbitrary line in the sand. So I think this is why some papers are not reporting p-values anymore, but you can still say that because the lower end of the 95% confidence interval does not cross 1, by definition, the p-value is less than 0.05, and based on what has historically been described, that's considered a statistically significant result. And then there's also the question as to whether it's a clinically significant result in terms of the effect size. And I would say that it is. The effect size was 1.37. Now, in terms of secondary outcomes, the ordinal distribution of modified Rankin score at 90 days, so that's including all the MRS scores, not just 0 and 1, the effect size was 1.33 in favour of Tenecteplase. However, it just didn't quite reach significance, so the lower confidence interval was 0.98. However, they did do a post hoc reworking of these numbers, which I'll talk to shortly. The other secondary outcomes, so having a score of 2 or less on the MRS indicating functional independence, was also favourable for Tenecteplase at 44% versus 33% in the control group, with an effect size of 1.31, and that was statistically significant. The major neurologic improvement at 72 hours was 16% in the Tenecteplase group and 6% in the control group. Again, statistically significant with a large effect size of 2.66. Reperfusion at 24 hours was 20% in Tenecteplase and 12% in control group. Again, statistically significant. And a change of the NEIS score at 7 days was found to be an improvement in 4 in the Tenecteplase group and an improvement in 2 in the control group, although that was not statistically significant, but a trend towards significance. In terms of the safety outcomes, so this is obviously also very important, symptomatic intracranial hemorrhage within 36 hours after randomization was seen in 3% of the Tenecteplase group and 1% of the placebo group. And that, of course, is a trend in favor of the placebo group with an effect size of almost 4. It didn't quite meet statistical significance because the confidence intervals was 0.82 to 17.87, but a clear trend towards symptomatic intracranial hemorrhages in the Tenecteplase group, as would be expected. Death within 90 days was very similar between the groups, almost identical. Moderate or severe systemic bleeding within 90 days was higher in the Tenecteplase group, so 2% compared with 1%. Again, didn't reach statistical significance, however. Any adverse event at all was basically identical between the two groups, and any serious adverse event was similar-ish between the two groups, so 20% in the Tenecteplase group and 17% in the placebo group, although not at all statistically significant. Now, this is the ordinal analysis diagram for those watching on video. So it's the bar graph showing placebo on the top row and Tenecteplase on the bottom row, with the percentages of each cohort included in an MRS of either 0 or 1 or 2 or 3 or 4 or 5 or 6. And then these diagonal lines showing whether the shift is to the right or to the left. And you can see that it favors Tenecteplase at all levels until you then get the shift between 5 and 6, which then the shift goes in the other direction. It's a little bit hard to describe this verbally, but hopefully you're getting the picture if you're just listening along, and otherwise you can see the diagram. So this is the post hoc analysis that they did here. So what they did is they combined groups 5 and 6. And is this completely sneaky or is this acceptable? I would argue that it is acceptable because you'll remember that an MRS of 4 is someone who can't perform their personal ADLs or they can't walk independently. And then an MRS of 5 is someone who's basically moribund and bedbound and completely dependent on other people. And then an MRS of 6 is someone who's dead. So if you've got an MRS of 5 and you're completely bedbound and dependent on other people for everything, that's, most people would argue, is not an outcome that should be being aimed for, and that would be considered a bad thing, not a good thing. It then comes down to a fundamental ethical question at a very moral, philosophical level as to whether it would be better being dead or alive if that was your quality of life, and that's going to be very individual value systems based. But I think a lot of people would say that the quality of life, if you've had a massive devastating stroke and you're completely dependent and you're completely moribund and bedbound, is not a very good quality of life. So if you bundle up group 5 and 6 together and then do the ordinal analysis, it then even more strongly favors Tenecteplase, and it does then reach statistical significance. So the effect size is then 1.42, and the lower range of the confidence interval is 1.04. So it then did reach statistical significance. Now, this I've just included because it was the efficacy and safety outcomes when they did what I mentioned before as seeming a little bit sneaky in terms of using an imputation model to extrapolate outcomes for patients with missing data, but I've included it just to demonstrate that it didn't really change significantly any of the results that I mentioned before. So again, in terms of the secondary outcomes, the major neurologic improvement was basically what it was previously. Same is true of the reperfusion at 24 hours, and the same is true of the change in the NIHSS score from baseline to day 7. Now, in terms of recanalization at 24 hours, so in patients who had angiographic imaging, we can see that the Tenecteplase group also did better. So they had a much lower percent of having no good recanalization, and they had higher percentage points for having good levels of recanalization. And the effect size here was 4.73, and it was clearly statistically significant. So having a score of 3 on the recanalization scale was 28% in the Tenecteplase group and just 6% in the placebo group. And conversely, having a score of 0, so no recanalization at all, was 50% in the Tenecteplase group and 71% in the placebo group. Now, this here is showing the outcomes, but using the per protocol analysis model as opposed to the intention to treat analysis model. And this is basically swapping the groups that the patients are counted in if they had major protocol violations. And what this demonstrates is that for the primary and secondary outcomes, it didn't have a major effect on the data points that I've already described to you. So I won't go through it all again, but basically using per protocol analysis, the primary outcome of an MRS of 0 or 1 at 90 days was still statistically significantly in favor of Tenecteplase, and the secondary outcome measures were all similar. Now, let's look at the parenchymal hematoma at 36 hours. So this is on the non-contrast CT brain imaging. So they divided this into 2 types of parenchymal hematoma. So type 1 was a blood clot not exceeding 30% of the infarcted area, and there may have been some mild space-occupying effect, whereas type 2 was dense blood exceeding 30% of the infarcted volume with significant space-occupying effect. So just to say that again, type 1, the amount of blood is less than 30% or up to 30% of the infarcted area with some mild space-occupying effect. And then type 2 is more than 30% of the size of the infarcted volume with significant space-occupying effect. So basically mild and severe. So the milder type 1 was seen in 2% of patients in the Tenecteplase group and 0.5% in the placebo group. And the more severe type 2 was seen in 1.5% in the Tenecteplase group and 0.5% in the placebo group. So about triple to quadruple in both instances. And again, there's a clear trend towards a more favorable outcome there from a safety perspective in the placebo group, as would be expected, although the study was insufficiently powered to demonstrate statistical significance there, but a trend towards intracranial hemorrhages in the Tenecteplase group, although relatively low patient numbers overall. Now, the subgroup analyses. We won't spend too much time on this, but this is a forest plot, and it demonstrates basically that it's a well-designed study, because even though the study isn't powered to demonstrate statistical significance in each of these subgroup analyses, many of them actually did meet statistical significance, and the ones that didn't basically all had a trend towards benefit for Tenecteplase. So it's a little bit difficult to describe this verbally if you're not watching along, but for all the subgroups, whether you were less than 80 or more than 80 years old, whether you were male or female, whether you had a NES of less than 10 or more than 10, whether you were randomized at 4.5 to 9 hours or 9 to 24 hours, or whether you had a stroke on awakening, and whether you had an M1 or an M2 occlusion, they were all clearly in favor of Tenecteplase, and some of them were actually statistically significant, whereas the others weren't, but all clearly in favor of Tenecteplase. The one exception here was the occlusion site of the internal carotid artery, so the intracranial ICA cases. There was a slight trend towards benefit in the Tenecteplase group, but only at 1.04, so very close to 1. So you could argue that the intracranial ICA patients really didn't convincingly do better or worse on Tenecteplase versus placebo. So the two groups were basically the same in that respect. And that then does raise a bit of a difficult question in terms of how do you actually apply the findings of this study to your clinical practice? Do you take the finding from the primary outcome and then say, well, this study was performed in these patients and the primary outcome favored Tenecteplase, so all these patients should then be treated with this drug if it's available? Or do you then look at the subgroup analyses and say, well, the patients with intracranial ICA occlusions didn't do so well on the Tenecteplase, so I'm not going to be thrombolizing those patients and I'm going to thrombolize everyone else instead? That's a really, really difficult question, actually, and that does reflect a bit of a difference in values and perspectives and ideas between different clinicians. So some people would focus on the primary outcome and not take too much notice of the secondary outcomes, whereas other people would really put a lot of emphasis on the secondary outcomes, even though the study isn't powered to demonstrate statistical significance in the secondary outcome measured. So I'll leave that up to you. But basically, I think it's fair to at least say that this study at least demonstrated that of the patients enrolled in the study, the one group of patients who arguably didn't do so well on the Tenecteplase and weren't really better than the other patients were patients with intracranial ICA occlusions, whereas everyone else did do better. So if you're umming and ahhing about whether to treat or not, then if it was an intracranial ICA, then that may sway you towards being less likely to thrombolize rather than being more likely to thrombolize, but it's still going to be a case-by-case decision. Now, this table here demonstrates a very similar finding to what I discussed previously, but it's using post-hoc subgroups as opposed to intention to treat subgroups. And some of the subgroups were defined in a post-hoc manner, so they defined the age cutoffs differently and some of the other cutoffs differently. So rather than just looking at the pre-specified greater than 80, less than 80, they, in a post-hoc manner, did analysis for less than 75 versus more than 75, less than 65 versus more than 65, whether the patients actually ended up having rescue mechanical thrombectomy or not, and also how big was the ischemic core at baseline? Was it less than 20, 20 to 50, or greater than 50? And again, in all of these cases, there was a trend towards benefit in the Tenecteplase group, so very concordant outcomes in the subgroup analyses. Now, this table here just includes all of the other adverse events that were looked at. Obviously, I'm not going to go through all of these. You can have a look if you're interested, but it just includes every adverse event you could possibly think of, basically. And there really was no statistically significant difference between any of the side effects that were looked at here. And of course, this isn't the ones that we've already talked about that were the primary safety outcome measures, but this is all the other potential adverse effects. So we can take a deep breath. We've been through the results. Now let's talk about what they mean. What do we make of them? And do we, and if so, how do we apply this to our clinical practice? And is this a practice-changing study or not? So firstly, I would argue that this study provides evidence. Well, actually, the authors argue this. The authors argue that the study provides evidence for thrombolysis with Tenecteplase in the extended time window, so 4.5 to 24 hours, in patients in whom immediate mechanical thrombectomy is not accessible. And I would agree that that is true, but just noting that these were highly selected patients with a baseline MRS of 0 to 1. The authors argue that the study also provides a rationale for thrombolysis in the extended time window with Tenecteplase when patients present to a smaller hospital prior to transfer to a mechanical thrombectomy center. And the words they use there is those patients may no longer be eligible for embolectomy by the time they arrive at the primary stroke center. So what they're saying there is suppose the patient arrives at the 12-hour mark and it's going to be a 6-hour transfer to the primary stroke center, then technically that patient is eligible for thrombolectomy, but it's just not available at the regional center. But then when 6 hours elapses and they get to the 18-hour mark by the time they arrive at the primary stroke center, there may have then been an evolution in the clinical state such that they're no longer a good embolectomy candidate. And I've experienced this quite a lot, actually, in terms of whether a patient actually ends up getting embolectomy or not, working at various sites in the last few years. So I've worked at some comprehensive stroke centres where we have a very large catchment area geographically of a radius of hundreds and hundreds of kilometres. And so we get the call about someone who is a thrombectomy candidate, but they're 4 hours away, 6 hours away. We say yes, and then we wait for them to arrive, and then they arrive, and then there's been a clinical deterioration or a partial clinical improvement or something else has changed. So then the interventionalist then asks for repeat imaging, and we repeat the angiogram plus or minus a repeat perfusion, and then based on the clinical and radiologic characteristics, the patient then isn't a thrombectomy candidate anymore. So they were when we got the phone call, but then they weren't by the time we got here. And so what the authors are saying is that those patients, so patients who present to a smaller hospital who are potentially candidates for thrombectomy, but then by the time they actually get to the thrombectomy centre, they might not be a candidate for thrombectomy anymore. They're arguing that those patients may then be a good patient cohort to be treated with Tenecteplase. I would argue that even though this is plausible, I think it's a bit of a stretch because the study didn't actually look at that at all. At all. The study did not look at that. So this really is a somewhat plausible extrapolation and hypothesis, but it hasn't really been empirically established. Then going back to this door-to-needle time of 139 minutes that I harped on about earlier, the authors note that this was similar to the door-to-needle time in the Extend trial, and it was attributed to the need for written informed consent and randomisation in the clinical trial setting. That's really interesting to me, at least, because it makes me think if I was a patient or if a family member was a patient and I presented with, say, a stroke and I was being offered enrollment in a clinical trial, if enrollment in the clinical trial was going to mean that I got a door-to-needle time of 140 minutes compared with standard of care, then if the standard of care was pretty good, then maybe I'd go for the standard of care. I guess it's not so relevant in this case because the standard of care was not thrombolysis, so it wasn't a choice between thrombolysis in a trial setting and thrombolysis outside of a trial setting. It was a choice between thrombolysis in a trial setting versus no thrombolysis at all. So it's not so relevant in this context, but if it were the case that the choice was between thrombolysis in a trial setting and thrombolysis outside of a trial setting, I think you'd be hard pushed to justify to yourself to actually be enrolled in the trial. And I suppose that's one of the factors that ethics committees would also have to consider when they're giving ethics approval for these studies. So you would have to consider how much clinical equipoise is there in regards to the clinical question being asked, and is that clinical equipoise sufficient that it warrants a trial being performed, acknowledging that you're going to get terrible door-to-needle times in the clinical trial setting. Just a bit of food for thought there, more than anything else. Now, what limitations were identified by the study investigators? So firstly, it was open label when it came to the administration of the medication, but as mentioned, the outcomes assessment and the statistical analyses were both blinded, so that at least limits any bias there. It lacks applicability to patients presenting to mechanical thrombectomy centres because those patients then have mechanical thrombectomy as an option, and so this study just doesn't apply to them at all. But of course, that was why this study was performed as opposed to the Timeless study, which was a negative study. Then again, the study was performed in China, where ICAD is more prevalent, proportionately speaking, compared with AF, compared with the ratios in Western populations. And so I spoke about that at the beginning of the episode. So corroboration with studies, including Western countries, would be important. The effect size is smaller than the effect size seen with thrombectomy, although I'd argue that that's not a big surprise. Thrombectomy is a great intervention with a number needed to treat of about 2 with a massive effect size, so I don't think you could really expect thrombolysis out to 24 hours to match the effect size of mechanical thrombectomy. However, interestingly, the effect size was similar to that seen in thrombolysis trials in less than 3 hours in previous studies, so actually the effect size was pretty good, all things considered. The authors also identified that relatively small ischemic core sizes and relatively mild NESs were included in the study. I mean, I don't think that the NESs were that mild. They did exclude NESs of greater than 25, so they excluded patients with really high NESs, but they included patients with good going knee scores up to and including 25. So that's going to catch the majority of patients that you see. And then regarding the protocol violations, importantly, 9 patients had enrollment when they shouldn't have been enrolled because of more than 1/3 of the MCA territory already been infarcted on the non-con CT and it was missed. And 5 of those 9 patients, so more than half of those patients, had symptomatic intracranial hemorrhages. And you'll remember that of the population as a whole, the rate of symptomatic intracranial hemorrhages was only about 2%, whereas in those who had more than 1/3 of the MCA territory involved, it was greater than 50%, so more than a 25-fold increase in the risk. So whatever you do, look really, 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 really closely at the non-con CT. It's very easy to get washed up in the CT angiogram and taken away by the CT perfusion and put all your emphasis there. But please take the time to have a close look at the non-con, because if there actually is a large area of hypodensity consistent with a large area of the MCA territory impacted, then you really, really ought not to thrombolyze that patient. And the authors reiterate that. And they also suggest the aid of autonomic CT software algorithms to identify this as well. And that's interesting. I've worked in some centers in Australia that actually have this. So they have an automated aspect score, which is generated by the computer algorithm. So that can be a helpful double check in case you do accidentally overlook it. It can just be a bit of a safety net to check. So it's quite helpful. And assessing an aspect score, an experienced stroke physician is very good at measuring an aspect score. I would say that it's not the easiest thing to do and the easiest thing to remember for your neurologist not usually working in stroke medicine, and for your non-neurologist, that's, I'd say, more into the advanced category. So it's not the easiest thing in the world to do. So having a computer to do it for you when the stakes are high and you're stressed out and you're deciding whether to thrombolyze someone or not, I think is quite helpful. Now, this is the last substantive slide, and it's just a few additional discussion points that were raised in an editorial paper which was published alongside the main paper. So the points that were identified in the editorial were that worldwide, it's estimated that less than 3% of patients with large vessel occlusions actually undergo mechanical thrombectomy, implying that the vast majority of patients who have strokes caused by a large vessel occlusion don't get mechanical thrombectomy, and a lot of those patients would present within 24 hours. And so at a global level, this study would have potential massive implications in terms of eligibility for some form of hyperacute stroke medicine by way of thrombolysis through Tenecteplase. And these last 2 points to finish off, I'll just read verbatim because it's well written. So the first thing that they say, and I quote, is that the use of Tenecteplase in the extended time window, and they're referring to a patient presenting to a non-thrombectomy center, in conjunction with a model of transfer to another facility for planned thrombectomy, was not well represented in either the Timeless or TRACE-3 trials and continues to remain a gap in knowledge that warrants further trials. So that's what we talked about earlier. This study doesn't really capture patients who present to a small center and then are being transferred to a bigger center that can do thrombectomy. What do you do for those initial patients if they're outside of 9 hours but within 24 hours and you can't give alteplase but you could maybe give tenecteplase? What do you do? So that is a big unanswered question. So that is something that people and policy writers at a local level and at government levels will need to make a call on, or they may wish to wait for further trials. And then the last point, which again I'll read out verbatim, is despite these limitations, the results of the TRACE-3 trial represent an exciting advance in acute stroke care. The use of tenecteplase in an extended time window provides a new adjunctive treatment option in our armamentarium against the most devastating type of ischemic stroke, and this has far-reaching global implications. In geographic regions that lack resources to develop thrombectomy programs, the administration of tenecteplase in the 24-hour window after stroke onset may be a practical treatment alternative that could improve functional outcomes in patients with large vessel occlusion on an international scale. So I thought that was a really nice way to finish up. And that's all that I have for you today. So thank you so much for tuning in. Please do like, comment, and subscribe, and tell all your friends and all your colleagues, and tell your seniors and your juniors and your students, because I'm really trying to spread this around so that people actually watch it and listen to it. Visit our website at rneurologyeducation.org for all of our media formats and additional content. Find our video presentations on YouTube and our audio podcasts wherever you listen to your podcasts, and join us on your preferred social media platforms, because we're on basically all of them, at Neurology Education. You can also email us at contact@rneurologyeducation.org with any questions that you may have, or to subscribe for updates when new content is released. From cortex to curiosity, this has been Restored Neurology Education. Until next time, keep calm and synapse on.